Oh, I have to click got it because it says it's being recorded. Just a second. Right. So we talked about maternal death and I showed you some stark metrics at the beginning. You don't have to read all of this slide. I'll pick the bits out for you. It's not just about maternal death, although that is very well evidenced. There are exactly the same trends for perinatal health. So, like minoritized ethnic groups are certainly at an increased risk of preterm birth, stillbirth, neonatal death, or small for gestational age at the time of birth, low birth weight and very low birth weight. And the example given on this slide is the risk of stillbirth in Black women is double the risk of white women at matched gestations. So this exactly correlates with the maternal death stats that I've already shown you. Next slide, please. But I'd like to extend the narrative beyond pregnancy and into women's health more widely, if you'll allow me. So there are lots of other things going on in women's health. And they might include things in gynecology, cancer, endometriosis. In our society and in other societies, the same ethnic disparities are found. So it is therefore not just about maternal death, and it is not just about obstetrics or maternity. It is at least about women's health in general. Next slide, please. And I suspect that you would agree with me that although these are some women's health outcomes where there are disparities, COVID either taught us or reminded us that it's about health full stop. So I guess now what I'm doing is I'm using women's health as an example for something which seems to be a painful to discuss truth in healthcare. I remember when it was the first wave of COVID, one of my friends in West London started telling me all about how it must be biology, which is the reason why Asian people and Black people are dying more. There's something very interesting in that to do with our, is it natural or not, a predisposition or a tendency to try and find other reasons for something when it's difficult to talk about. Have a look at the next slide. So the next slide is up for this reason. I remember one of my own colleagues, a fantastic person who I love and value, when the story of ethnicity and COVID started building, their first reaction was to suggest that it might not be about ethnicity, it might be about deprivation. So they didn't hide behind biology, but they thought it might be about one of the other markers for poor healthcare. What this slide illustrates is that although there might be a paucity of information from the United Kingdom, from other areas, but particularly the United States, what might need to be addressed here is in fact racism. So I'm not afraid to use the word. And I think I spent 20 to 30 years being afraid to use the word at work. And I've become not afraid. And you are all much better than me. You're younger, you're probably cleverer, you're probably more dedicated to your craft, and you're talented. But will you be brave? I want you to find ways to acquire the bravery I've only acquired more recently. Research in America shows, and I'm reading it out, that implicit racial bias and discrimination is evident in the US health system. And it's always been evident, but people were reluctant to talk about it. Racial bias plays a part in poorer health outcomes. It is not just about socioeconomic deprivation. There is more to it than that. It can feed into a negative feedback cycle whereby Black and Asian and minority ethnic women and men avoid healthcare. They avoid interactions with professionals. They've been treated disrespectfully or badly before, so they don't go and they present late. We can call this a stereotype threat, more of which a little bit later. And this is not necessarily on purpose. It is unintentional often. It is unconscious often, but it happens. And we're doing it now, right now. in healthcare in the United Kingdom. If we think about an ethical framework and what feels right, this is quite other. This seems not what I went to medical school for, to start thinking about this way. But we were aware that there's an ethical framework for doctors to think about things. Next slide, please. And you can look at Article 12 of the International Covenant on Economic, Social and Cultural Rights to find a statement about health being a fundamental human right. Well, that means for everybody. Human is not a word where color should come into it. Every human being is entitled to the enjoyment of the highest attainable standard of health, conducive to living a life in dignity. Next slide, please. So why is this so difficult to talk about? What is making this so very difficult? How do we feel when we see the short phrase, I felt humiliated? How does that make us feel? This is not what you went to medical school for, is it? To make someone feel humiliated? You won't. Maybe you won't. Or you won't consciously. All of us have, unfortunately, the ability to make people feel uncomfortable or bad, but not necessarily on purpose. So this is why in the learning objectives, I've tried to make a link at this point with things which are very sensitive to talk about, because only then can we link about how to try and solve it. So we're going to, in the next few slides, we're going to see some quotes and statements from real patients who had maternity care. And I work in maternity care. I'm a doctor, I'm an obstetrician, and it's difficult to read. So let's go to the next slide. Let's look at some of these. I felt unsafe. And I felt like maternity professionals are not used to being challenged by brown women. Such an important word coming up, stereotype. So this is where the sensitivities come in. There is a stereotype of Asian women that we are tame and quiet and compliant, and we have no voice and we're obedient. Now just have a think about how stereotypes can subconsciously influence the way in which we consult and the way in which the wider multidisciplinary team consults. Let's think who the MDT is in maternity care. So we have midwives, they do most of it. They do all the hard work. We have obstetricians. We have anaesthetists. Actually, everybody likes them because they give you an epidural. Or do they? Pain is one of the big sensitivities that we're going to address, all right? We have neonatal medicine specialists. And we're human beings, and we sometimes come to work with our own prejudices and our own preconceptions about things. But at the same time, we're professionals, presumably with a commitment to fairness and equity. So why are we not delivering on that in terms of outcomes? Is there something stopping us from even reading statements like this? Because we know it means we need to address something quite dark, guys. I was treated like a vessel, not like a human. So that's dehumanization. The experience left us feeling humiliated, disempowered, ashamed. During labor, I was denied pain relief, and I was told that I must have a low pain threshold. If you talk to professionals working in sickle cell anemia, that is a racist trope. It has been around for a very, very long time. It is not based on evidence. It is false, and it persists. Next slide, please. A woman of Afro-Caribbean heritage said her first experience of her service was that she couldn't find a category to match her own ethnicity and was told to pick another one. She waited for hours and hours to see someone who it turned out had gone. When she tried to get help, she was called aggressive. This is racism. Feeling I get when I talk to people about their experience is that I was not heard or believed or trusted. They were not heard, believed, or trusted. I have seen it time and time again. So people like me have failed. We hit this on my watch. We have watched this happen for at least a generation and have felt that we didn't know what to do about it. You do have to bear in mind that I'm older than you. I had to overcome perhaps, and I only now reflect on it, certain things myself to even get where I wanted to be. And some of those same ideas around not feeling that you can even speak up or seek help might sometimes apply to healthcare professionals. One of the things I do with the Royal College of Obstetricians and Gynaecologists, I look at something called differential attainment. It's very important. It's not about healthcare directly. It's about health professionals, whether they can even get ahead depending on their ethnicity. And I've got loads of data about exam pass rates and yearly outcomes showing they can't. If you're white, you're actually more likely to pass exams. Why is that? I'm talking about British trained people, British medical schools. And then a tip to the future, there's some unlearning to be done in terms of how people are perceived. So these, in my learning objectives, I referred to this with sensitivities. These are the very, very sensitive topics that I think we need to start to address. And the 5 Times campaign is helping us. As sometimes happens, in theory, this is a problem for society or systems, or some people might feel white people to solve, okay? But as often happens, it's the people who've been subjected to things who are the first to speak out. And so the 5 Times campaign is a campaign really revolving around Black women who have come to the conclusion that they have had enough and are going to keep speaking at the highest level. Next slide, please. So they are committed to highlighting and changing the outcomes. And they demand answers as to why this is happening, but they also demand access to address the disparity. So we now get on to the last bit, which is, by now, I'm sure like me, you want to know what's next. Next slide, please. You want to know what we can actually do. And what we can start to do is outlined on the next few slides. So there are 2 slides which the 5 Times campaign have produced for you and me, for health professionals. They're telling us what we can do now. We can listen. If someone expresses concern, actually listen to what they're saying instead of making assumptions or presumptions. And try to understand that people express their emotions differently. And sometimes these things are culturally bound, but they are still an expression of emotion, and try not to negate it. So in other words, it's not necessarily how something's said, it's what someone is saying. Try to think about communication barriers. I spent the afternoon in an antenatal clinic with no interpreter available, and I was almost very late for this talk because trying to get interpreters on the through language line on the telephone is onerous, time-consuming, but is necessary, because for a woman to have adequate advocacy, it may not be okay for a rather domineering husband to so-called interpret and then, in fact, not interpret, not translate anything. Don't forget your tone and your body language in keeping someone at ease. Next slide, please. 3 to go. Try to make sure that the information you're sharing is clear, and test whether you shared it correctly by recap tests with the woman, a bit like when you're testing for capacity, and give genuine space for questions and allow genuine verbal consent during consultations. Try to think about documentation. Offer second opinions if they're wanted. Don't dismiss. Make sure that this support is accessible. So many women of colour report a lack of support and a lack of engagement. And then finally, be me. Be a champion for this stuff. Be unafraid to talk about it. Support the research. Do the research. You'll be better at it than me. And try to champion positive change. And people use this phrase, polishing the problem. Don't polish the problem. Don't talk endlessly about what the outcomes are now. Talk about what you're going to do for the future. The medical establishment in women's health have adapted this to try and help young doctors. Next slide, please. So what was 5 points became slightly changed, perhaps 6 focused points around communication, being women-centered, trying to make a diagnosis rather than just excluding one. And that's part of not negating someone's lived experience of symptoms. Getting a second opinion, being an advocate or finding one, and listening. Okay, next slide. And this is now a national story. So I'm very proud that I'm a very small part, but a part of a bigger group at my Royal College who are determined to keep talking about and keep solving these issues. That's the RCOG Race Equality Task Force. I hope that in due course you get a chance to, if you can, attend some of their online events. They are very interesting. And you may even wish to join the work, because we do have undergraduate representation and we want more. And the next slide is my invitation to you to reflect, next slide please, on what I've said, and I'll now open it out to questions. Thank you very much.
Thank you very much, Mr. Khan, for such an inspiring talk. It's truly been absolutely amazing, and I'm sure a lot of us in this call today will agree that all of these issues are things that have to be addressed and things that have to be approached more sensitively. And it's a good thing that they're coming out now for more people to actually speak about them. So I've got a few questions popping up at the moment. So first of all, the term BAME seems to be having acceptability issues at the moment. What would you say in response to this?
We discussed that at length at the RCOG, and we've consulted externally to see if there is a single answer, and it would appear there is not currently a single answer to that question. So if we think about all the different terms, the discrepancy is, if you look at the relevant academic literature in this area, where they have ended up is the word minoritized. So that would be what we would replace it with. The difficulty with the word minoritized is a lot of people don't actually recognize what you're talking about. So at the moment, we know what BME might mean and what BAME might mean, and we know what people of color might mean. Words are difficult. People feel judged. And feeling judged is not probably the route towards success with regards to this issue. So the truth is, you were right to raise the issue, and we cannot find an adequate answer at the moment. But from an academic point of view, the answer is the word minoritized.
If that is the case, then with the word minoritized, would that imply that there is a group of people, so-called the minorities? Do you feel that maybe some of them wouldn't like sort of the association of being minoritized, or perhaps they don't feel that they belong to the group of women that may experience more adverse outcomes or more issues in health? And how do you approach that?
It's entirely possible that people labeled minoritized might dislike that. And it's also possible that people labeled majoritized might like that. Our business is to try and deliver care which is safe and which is effective and which is kind and compassionate. Maybe the way through this is to use labels to think about global outcomes, but to escape from those labels when we're actually thinking about our care for individual women, who are, after all, people.
Mm-hmm. Thank you very much. So another question is popping through. What can we do as medical students to ensure we are part of this advocacy?
You're my colleagues now. Just because you're a medical student doesn't mean you're not part of it. So if you see something, use the rules of feedback, do it, but do it immediately, do it in private, say, can I give you some feedback? Start calling stuff out. You can be gentle about it. So my evidence that you're allowed is that if you see you're medical students and you are told if you see a patient safety issue, you're supposed to do something about it. I humbly suggest that this is an example of a patient safety issue. You therefore have a framework. You already know how to escalate this. because medical students are given information and signposted about how to escalate their safety concerns. But actually, what's perhaps more exciting is the championship bit. So maybe one of the many ways in which Barts and the London School of Medicine and Dentistry, Queen Mary University of London, could show that it is the best medical school of all is to extend itself by creating the right kind of dialogue and forums and clubs and societies to champion this nationally and globally. I would be so proud if this medical school was the medical school known for that. And I would also think entirely commensurate with where we are in East London. That's my challenge to you and to this medical school. Why not be the best medical school at this just because you want to be?
Thank you. We shall endeavor to try our best, certainly. A couple more questions popping up. Are there still adversaries for healthcare professionals of color in ONG?
Yes, there are. What was the word, adversaries?
Yeah, adversaries. So
that means enemies. Adversaries means enemies. Is that actually what's been asked? So do I have enemies?
I suppose maybe people that might see you in a particular way in the workplace because of your color, for example. I suppose that's what they mean.
Yeah, the answer is yes.
How would, if people were in this position in Obs and Gynae, what would you advise for them to do?
Isn't that an interesting question? They're not part of the problem. Maybe my advice isn't to them. Maybe my advice is to the people who are letting the problem happen. That's the department. Okay. So the Race Equality Task Force is trying to empower departments to feel they can do something about this. In order for that to be effective, we have to consider what the problem is and whether people accept it's there. I can't emphasize enough that people don't necessarily want to. Guys, if you've joined this forum tonight, you're interested in this. I promise you there are health professionals not interested in this. They're not going to join this forum. They're going to regard a forum like this as part of the quote unquote woke agenda. If you disbelieve me, try to think about how algorithmic systems within Instagram, Facebook, and Twitter narrow your social circle and narrow the field of opinion that you're exposed to. This is something we all know, yeah? So that's no less true of nurses and midwives and doctors. Now, we happen to be in East London, it's pretty multicultural, but even in East London, there are elements of this. If you look at a news story from within the last 7 days in the BMA, they talk about which doctors are shortlisted depending on colour. And Barts in the London, or Barts Health is as guilty as any. I'll leave you to look at the stats. But within departments, if you arrive at the idea that there should be accountability for fairness, then there is scope to move forward. And then we can address some of the problems such as differential attainment in exam pass rates and annual review pass. But it's actually very important even at the level that you're at. Interestingly, did you know that there's nothing in the way of differential attainment at A level? It's a level playing field. And the second you enter medical school, it changes. So there are clear differences illustrated by Professor Kath Wolf at UCL in whether you pass MBBS, depending on ethnicity. And those start playing out in foundation selection and everything after that. So there is an argument that it starts very early and it starts at medical school.
Very interesting. I think stemming from your answer, another person is asking, do you find you have to challenge colleagues' behaviors or views often?
Yeah, but I'm really bad at it because they're also my friends. Midwives and nurses and doctors I work with, I've been about, not before you guys were born, but I've been a consultant at the Royal London for about 14, 15 years. I'm like, hang on, when did I start? What year is it? 2021?
2021.
No, not 15, about 14 years. I started in early 2007. Is that 14 years? Nearly 15. I've never been very good at challenging people. I'm actually quite meek and mild by nature, and I don't want to challenge people. What I actually want is for allyship from other people if they see something unfair happening to me. Now that's worth thinking about. I think I've got better at it. And if you were to ask me, have I done it? It's been extremely painful, but the answer is yes.
Okay. And how can you prove that racism in healthcare, in interactions between patients and healthcare professionals, when a lot of it could come down to microaggressions or more subtle forms of racism?
So microaggressions and subtle forms of racism are part of racism. The question is actually is a reasonably academic question. So from a quantitative research point of view, I suppose if you introduced a program of interventions to reduce the frequency through education and through line management of systematic racism or systemic racism, and that included something about microaggressions and reporting systems and so on, you could, in theory, do some sort of cluster RCT. I've never heard of that being done. In theory, you could do it Barts Health because it runs 5 hospitals. You could randomize them to introduce the program or not, and you'd see if there was a difference in outcomes. I don't think it's like that. I just wonder if this is more to do with qualitative research, which I am not an expert in. The word proof is very difficult. I can show you evidence. I can show you potential interventions. If society had proof that these worked, that would be helpful for society in general. I just wonder if when society is under stress, perhaps prejudices come out more.
I wonder if this person perhaps meant it if he or she were in a situation where they perceived that there were a lot of microaggressions being sort of, around in a department, and they felt themselves that they were microaggressed in some way, that how can they then raise an issue and then have quote unquote evidence of feeling this way because of these subtle forms of racism, essentially?
Okay, so that's a very interesting question. But I guess the answer is, in theory, there are professionals who are trained in order to have those conversations, in theory, and they're human resources. So they are not me, other professionals with training in that. And increasingly, human resources professionals are trained to have conversations with individuals who perceive they've been subjected to racism. And that includes not only the idea that that person might describe microaggression, but that the HR person might deliberately inquire about microaggression, even if the person subjected to it didn't say anything. My experience is that people are so reluctant to report that by the time they report, it's blindingly obvious what's happened. So I acknowledge that there might be the idea that there's something unprovable about microaggression, but actually I believe the narrative is changing, and the relevant professionals are now more understanding that these things are real.
Okay. Thank you. Couple other questions. So we have one person who's saying, should we not stratify or disaggregate data by racial categories? Or should we just understand that racial categories are not proxies for genetics, but likely proxies for socioeconomic factors?
I think we can do both, but I think it's very complex. So if you stratify, then you have to have an agreed definition of what the different parameters are for different racial characteristics. And we don't, and we haven't even discussed mixed race. Okay, so the word minoritized then becomes very interesting, because suppose we were talking in India right now, we wouldn't necessarily be talking about color. What we'd be talking about in truth in India, and my declaration of interest is I am Indian, is we'd probably be talking about religion. So we'll be talking about whether you're Sikh, Christian, or Muslim, and what the outcomes are there. So it becomes very complex from individual society to individual society. Repeat the question again.
Sure. Should we not stratify or disaggregate data by racial categories, or should we just understand that racial categories are not proxies for genetics, but likely proxies for socio-economic factors? So I suppose what this person is asking is...
So race is not...
Okay. Oh, sorry.
So race is not a proxy for socioeconomic factors. It is co-associated a lot of the time, but is not. Evidence from the United States shows that it is different. It is an independent risk factor. I think disaggregating by different types of race is what we currently attempt to do, but it's far from perfect. The point is well made, therefore, that you actually have to think about systemic racism. I would make one observation about the biology side of things. Those of you who've got this far will know that antihypertensive drugs are given differentially or prescribed differentially. Where's your light gone? Depending on ethnicity. I think many of your audience will know that. What's very interesting is how it came to pass that we discovered this. And looking back historically into research, what you actually find is a lot of the time biomedical research has focused on the majority and has ignored the minority, resulting in the minority getting inadequate treatment. So we actually need a quantum leap in how we think about how we synthesize evidence. I might have to go soon. I've got to take my boys for a COVID test and they got an appointment time.
Absolutely. I have one last question. Do you think you might have time for one more, or?
Yeah, one more, yeah.
My last question is, in terms of higher morbidity in pregnant mothers from BAME backgrounds, if you could choose 3 main reasons for this, what would they be?
Oh my goodness. I don't know how to answer that. So I won't. And instead, I'll make an observation. In the United Kingdom, you can divide maternal death into direct and indirect. Direct is things that I've done, such as made someone hemorrhage. Indirect is not necessarily things that I did, but something went wrong, e.g. someone had heart disease and no one did anything about it. What's very interesting is that direct deaths are falling in all groups, but disproportionately indirect deaths are neither falling, but they may even be going up in some groups, e.g. Black African. So I haven't answered that question at all because I don't know how to. I think I'll have to say goodbye now, but it was really kind of you to invite us.
Thank you very much for the lovely talk, Mr. Khan. It was a pleasure to have you.
Okay, bye.
Bye. So to everyone else, please don't leave quite yet. I would like to introduce Gawai, who is the representative of Elly charity. And I have to say that we are incredibly excited to be working with this charity this year. They're very committed to bringing you lots of opportunities, and it's definitely worth staying for a couple of minutes while she's introducing the charity and the opportunities that they're bringing forward for you. They're very committed to educating and promoting research to make positive changes in women's health. So without further ado, I would like for her to give out a bit more information herself.
Hi, hello. Hi, Sonia. Thank you very much. My name is Nawai Moss, as you said, and I work for Elly Charity, and we're delighted to be working with you. And thank you so much to the Society for choosing Elly Charity to work with this year. I wanted to just say a few words, I won't keep you long, just about our charity and what we do, and just what we're thinking about doing in the next year ahead, and some routes to collaboration as well. I'm just going to share my screen just to show you some photos more than anything. Let me try and find, oh, it's not coming up. Yeah, it's okay. I'll try again, 2 seconds. Oh, here it is. So I just wanted to share with you some photos about our charity. So we started as the Elly Appeal in East London, and we're based in East London. And we started doing some work in the community, but also doing work internationally and going to low resource settings and really focused on education. And these are some of the pictures of things that we've done and our colleagues and volunteers have done in the last few years. And our charity, we got registered status last year, and we have 3 kind of pillars of what we do. So one is around education and training to provide the best care during pregnancy and childbirth. So that's also really a nice link with the society, because we're really keen to promote this, and not just, you know, in East London nationally, but internationally in different levels. So education is really important for us. And we're also interested in research and supporting the best research in women's health, including involving patients and women and the public in setting the research agenda and making sure that the research is relevant as well. And we're so lucky to have in East London a women's health patient public involvement team called Katie's Team. So we're really excited about that, and we're such a lovely group of women and well, just a community really. So that's fantastic. I think 1 or 2 of you might be here on the call tonight, and that's linked in with QMUL as well. And then also the charity is very keen to make sure that research findings actually make their way into practice, into women's healthcare. So they're like our 3 key pillars from our charity perspective. And you know, before COVID, we used to go and have different trips and travel to kind of low resource settings and do really intensive training in lots of different countries. In 2019, before all this happened, we were in Borneo, and you can see the team up here at the top, which is, you know, such a great team. So then last year, obviously with COVID, it's been quite difficult. So we focused our work on doing a sort of a webinar series about COVID in pregnancy, and we managed to get some great speakers talking about antenatal care, intrapartum care, postnatal and neonatal care during the pandemic. And this was at the height of the pandemic, and we've got some great videos. So if you want, go to our website, you can see the links to the videos there, or just you can also type in #GlobalPregCov as well, and on YouTube, and you can see those come up. And we also did one on women's health research during the pandemic as well. And we have speakers from WHO, from, you know, from India, from Switzerland, you know, and we had some mums as well talk about their experiences of being pregnant during the COVID period, and how research is important in that context. And when the vaccinations came through, we also did earlier this year another webinar on vaccination in pregnancy. And actually Mr Rehan Khan was a part of a couple of those, so it's interesting to see him in a different capacity as well. But we were very lucky, and we got such a great interest in the UK but also globally, and we've had thousands of views, and even we had lots of sign-ups from about 50 different countries. So we were really delighted how that went. So then this year, so this here is Mr Ram, and he is our trustee, but he's also the founder of Elly Charity. And he's been instrumental in getting Elly Charity off the ground and moving it forward. And now we're just so happy, really, that this year we're going to do some work with the society, and hopefully maybe with some of you as well. We have a couple of opportunities just come up to do some research projects, mainly in East London, but collaborating and co-producing them. And this is also linked up with Katie's team, the patient public involvement group, so that's going to be really exciting as well. And there'll be other opportunities, so please watch this space, and hopefully we'll get to work with you in some capacity. Thank you very much. Thank you.
Thank you very much for that lovely talk, Nawa. It's a pleasure to have you here with us, and that talk was amazing. I'm just going to share my screen very quickly to put some QR codes up in case, well, we have some for donations, but I also wanted to signpost to something that we posted recently. And let me see. So, yeah, I put some QR codes for some donations, but this weekend they need some volunteers to be role players for the MRCOG Part 3 OSCE exam, and this is a relatively paid opportunity, so if you stay there for half a day, you'll be getting £15, and this is something that has been forwarded to us by Elly charity. So if you email the email address that's here in this picture, or you go to our Facebook or our Instagram is there as well, and specify your availability, name, contact number, and the fact that you're a medical student and have an interest, they will be able to hopefully accommodate you unless it's full already. There's always a chance. But this is one of the examples of something that they have brought forward for you guys. Another thing is this Sunday is the deadline for some publicity opportunities. That's also in Facebook. So things, you know, to do with furthering CB opportunities. And finally, the deadline that we've just finished was one for research. So many lovely things coming from Elly, and we're very excited to be working with them. Just some final words. Thank you very much to everyone for coming today. It's been a pleasure. Please fill out the feedback form, which is in the group chat at the moment. And then we will email you the certificate, as Fran said, if you're part in the London medical student, and if you're a subs-paying member for our society. Otherwise, thank you very much for everything.
Yeah, thank you so much, guys, and thank you so much to our lovely speakers. And yeah, we'll see you guys at the next event, which will hopefully be in like November time. So just keep an eye on our socials and your emails as well, and you'll hear more from us. So thanks for coming, guys. Okay, everyone's gone. You guys wanted to stay on and chat, didn't you?